this week on the BackTable Podcast.
I didn't give up my day job, so to speak, in order to become a surgeon innovator. And I always felt and continue to feel that if you want to be a good surgeon innovator, you better remain a surgeon. You better be in the operating room, doing the procedures and experiencing the shortcomings of current techniques while contemplating what you can do to make them iteratively better. If you have a spectacular idea and you want to do some kind of dramatic alteration in the approach, that's great, but those don't come along very often. Most of the time, they're small, iterative improvements that spine or other surgeons are able to afford the field. But you got to be a spine surgeon, or you have to be a surgeon in general, or a practicing physician if you want to become an innovator.
Hello, everyone, and welcome to the BackTable MSK Podcast, your source for all things musculoskeletal. You can find all previous episodes of our show on Spotify, Apple Podcasts, and on BackTable.com. This is your host, Jacob Fleming. I'm an interventional musculoskeletal radiologist in Dallas, Texas. And today I have a very special guest, Dr. Jim Marino. He's a retired orthopedic surgeon, innovator, and some have called the bone graft whisperer. So Dr. Marino, welcome to the show.
Thank you for having me, Jacob.
Well, very, very excited to talk about this topic. Thank you for reaching out and suggesting this, because on our show, we're very interested in talking about the vanguards of musculoskeletal medicine in all directions, whether that's surgical, interventional, or otherwise. And minimally invasive bone grafting is something that really could raise some eyebrows, because otherwise this is a topic that has gone for many decades without a whole lot of change.
Sure.
So really looking forward to talking about this. Before we dive in, could you please tell our audience just a little bit about your background, perhaps your training, and just your career path so far?
I'll be glad to. So currently I'm retired from clinical practice. I practiced exclusively in the San Diego area after finishing my residency at UC San Diego. And I was both an orthopedic intern and an orthopedic resident at UC San Diego, and finished many moons ago in 1984. And I was pretty anxious to get going in my clinical practice, so I was actually board certified before I was 30 years of age, and was in private practice as an orthopedist here in San Diego. And basically, I've always been in private practice. I've had a limited affiliation with the university in some, small teaching capacity, but mostly it's been private practice. Before I came to San Diego, I was a medical student at Howard University in Washington, D.C., where I finished in a 3-year honors program. And prior to that, I was at Tufts University in Medford, Massachusetts. I finished there with a double major in chemistry and biology, also in 3 years. And I grew up on the East Coast in Teaneck, New Jersey, which is a suburb of New York. It's only about a 15-minute drive to Upper Manhattan. And grew up in a very nice suburban community with a very, I'll say, diverse population of post-World War II babies that came from a variety of ethnic and religious backgrounds. So I feel I was very fortunate. I had a very good youth, and I was the second child of 4 boys in my family. So we ended up with 3 physicians and 1 attorney out of the 4 of us.
Wow, pretty good odds there. Just 1 attorney. I think that's acceptable. But no, just joking, of course. But fantastic. Thank you for sharing that background.
Sure.
And you've really made it kind of all over the continental U.S. But once you made it to the West Coast, have you stuck there?
Yes. So the primary reason I came to the West Coast, and I would have considered Florida or even Texas, was because I had contracted polio at the age of 2 following a Salk vaccination in which the virus was not fully killed. And that left me with bilateral lower extremity weakness that was very profound initially. I wasn't able to walk for quite a while. Eventually, long leg braces bilaterally. Fortunately, my right lower extremity was less affected than my left. Eventually got rid of the brace on my left limb as well, and walked, I'll say it as almost as normal as anyone else, of obviously with a shortened limb and a weakened limb, but I was able to, when I was younger, walk unlimited amounts. With time, I've experienced post-polio syndrome, and there's been a degrading of limb function and strength in both lower extremities. And now I'm a limited community ambulator. I can walk within the confines of the home as much as I want, but when I'm outside, I can only walk short distances and have to sort of sit or rest. And I've never been a runner. I was never able to run ever in my life, but I could hop pretty fast on one leg at one point.
Thank you for sharing that. That is very interesting. And I wonder, did that have some significant impact on your choosing a pathway into orthopedics?
Most definitely. I can remember from the very earliest age, and I mean preschool, indicating that I wanted to be an orthopedist, not a physician, an orthopedist. And that's because I had excellent orthopedic care. I had a number of surgeries in my youth, and I actually looked forward to the surgeries because I recognized that each one was for my benefit and ultimately proved to be beneficial. I had epiphysedesis, I had tendon transfers, I had triple arthrodesis, which is a fusion of the hindfoot. I've had a variety of orthopedic procedures to make me more functional, and they all proved to be beneficial.
Amazing. And I think the perspective that comes from that is so invaluable. Many physicians have said that their experience finally being on the other side of the curtain, so to speak, really opens up the vantage to understanding things from the patient point of view. You grew up with that experience to a very significant extent, and that's really amazing. And I'm sure that this has had a very, very noticeable impact on your drive to innovate in your career. Could you tell us a little bit about that?
Well, yes, I'm sort of doing my best to characterize why I am the way I am. But when you have, and I did have, and I've always had a fairly profound disability, but you want to be as normal as possible and participate in as many activities as you can with your peers. So that leads you to have to do some problem solving, innovation, and be resourceful, if you will. And I think I've always tried to achieve through problem solving in various capacities. And I was very blessed with excellent supportive parents, particularly my father, who is a physicist and who instilled in me at a very early age the value of problem solving, rational thinking, and sort of instilled also all the fundamentals necessary for a fairly, I'll say, scientifically oriented approach to this world. And that's not to say that I'm not very spiritual. I am, but I think I'm very well grounded in rationality and science. And when you're problem solving, it helps to have that kind of a background.
Absolutely. And so tell us about, you started your career in private practice
Yes.
out in California.
Yeah.
And just tell us a little bit about getting started with that. Where did your career take you?
So the years that I trained as a residency were in the basically early 80s. And that was an area of both rapid development in the arthroscopic techniques and lots of early innovation. In my first year of residency and my internship year, we used to admit patients for their meniscectomy, their knee arthrotomy the day before, keep them overnight, and then operate on them and maybe keep them in the hospital for 1 or 2 days. And at the very end of my residency, and as I entered into private practice, I was doing arthroscopic anterior cruciate ligament reconstructions on an outpatient basis. So I saw a very dramatic change, a really revolutionary change in surgical applications that involved minimally invasive approaches to what were previously more obviously invasive techniques, and could see a substantial difference in not only the tolerance of the procedure with respect to the patient from the patient's perspective, but also I could see that by minimizing the collateral injury to healthy structures, we were able to get better outcomes, more predictable outcomes. And in fact, we were able to see better with arthroscopic techniques than we could with open techniques after we acquired skills and techniques and instrumentation. So there was a lot of new instrumentation being developed, new techniques, and the surgeons had to develop these skills sort of on the fly to keep up with the pace of development in the field. So I was very anxious when I finished my residency to be a peripheral joint arthroscopic expert and surgeon, and felt equipped to do that. But my patient population didn't accommodate. I was getting people with low back pain and radicular symptoms, and they constituted the majority of patients who were referred to me. And I made an early career decision to enhance my training through a variety of methods and limit my spine application practices to degenerative lumbar disorders. So I knew I wasn't going to be a full-fledged, occiput to sacrum spine surgeon, and I wasn't going to be a deformity surgeon. But I did feel as though I could become sufficiently capable in both diagnostic and therapeutic areas of orthopedic application for degenerative conditions, such as, degenerative disc diseases and spinal stenosis. And that's where the majority of my practice ended up being focused on. And that's where I developed a very limited but local reputation for competence.
Fantastic. And I really love that pathway that at the time you came out, you were planning on one thing, and then the patient population kind of drew you to another thing. And so you took it upon yourself to do what was necessary to be able to provide the care they needed.
I mean, at first, I maybe I was overconfident, but I felt very capable of doing most orthopedic applications, foot and ankle, some hand surgery, lots of trauma, because UCSD was a trauma center, and I did several rotations as chief resident on the trauma services. And I felt very capable as an arthroscopic surgeon, and not so capable as a lumbar spine surgeon. That's why I made sure that I attended all the spine conferences that were available that I could go to, all the early NAS meetings. Whenever I went to the academy, I tried to focus on attending the spine courses. And then there were a variety of courses throughout the year with hands-on experiences, because this was also an era when segmental fixation was just more or less taking off. There were, from Cottrell Dubuisset, there were some obviously early adopters in the area, in Europe initially, and then subsequently in the United States. But we were going from Harrington and Luque rod type fixation to pedicle screw fixation during this period when I was basically finishing my training and entering clinical practice. So I tried my best to become as familiar as I could with the techniques in pedicle screw fixation, and was fortunate enough to, I think, become sufficiently adept to provide my patients with good care.
Reflecting back on those early days of lumbar spine surgery, evolving as it was at the time, as you described, how do you see things now, kind of the grand scheme so far, going from back then in the 80s to where things are now? Do you think that it's completely unrecognizable, or is the pace of innovation not as much as it needs to be?
Well, let me try to answer that question thoughtfully. The need for improvement obviously will always be there. And there are many innovators in the field of spine surgery that are constantly trying to improve the field. And there are technical breakthroughs that occur periodically in the field, but there are also some enduring principles that carry over even from prior to segmental fixation. We understand that decompression alone is usually not the full answer when it comes to certain diagnoses in which you have segmental instability or pain from motion segments, and or you, in the process of doing your decompression, destabilize the spine. And I can remember in my residency years, we used to see patients coming into clinic with progressive deformities following decompression procedures because it had not been appreciated how important it was to provide stability post-neurologic decompression. And segmental fixation gave us a great tool and also a great understanding for the mechanical loads that were being placed on the spine following decompression procedures. And so I think the principle of stability is one that's going to endure forever. Obviously, if we can decompress with less destabilization, then maybe we don't have to fuse on certain procedures that we are currently fusing. And I'm thinking particularly of spinal stenosis, degenerative spinal stenosis in the elderly population, where the fusion intervention is more surgery than we wish to, let's say, apply for these older patients. There are advances that are being made there in endoscopic techniques that involve decompressing the spinal canal and the lateral recess for, recess stenosis that do not involve facet resections or significant ligamentous destabilization. So I do think that there is movement in this area. Some of it's occurring outside the U.S. more rapidly than within the U.S., but it is spreading. I mean, it is an international field, and these trends are certainly certainly the advent of cervical arthroplasty as opposed to anterior cervical decompression and fusion has gained a lot of traction, and a lot of surgeons are applying cervical arthroplasty as opposed to decompression and fusion for some cervical degenerative conditions. I think there's areas for advancement locally, that's in the United States, in utilizing the laminoplasty techniques, which are more popular in Europe and in Asia. And I think as more and more spine surgeons become familiar with the benefits of laminoplasty and its various forms, we'll see more of that done in the U.S. I think one of the major areas for reflection and improvement is probably indications. Indications for surgery should be more standardized. And by that I mean that there shouldn't be as many opinions about what to do for the same set of symptoms and radiographic findings. There just seems to be a lot of individual, if you will, approaches to spine that are not necessarily justified by the literature that's available. And I worry because we have so many very talented spine surgeons being produced through the various fellowship programs. I just worry that there's enough material to keep them all busy and that their indications will remain objective and appropriate.
That was fantastic. You touched on so much in that answer. And to your last point about differences in an operative opinion, reminds me of the old adage, if you ask 10 spine surgeons, you'll get 11 different opinions on how to approach a case.
Yeah, we
But
change our mind in the middle of a sentence.
But more seriously, you mentioned fundamentals and foundational principles. And one thing I've always appreciated about orthopedics and spine surgery is things like the AO principles, understanding basic physiology of bone biology and healing really underlies everything. And as you were talking about these different approaches that have come through with time, and the endoscopic approaches have been one of the things that's really excited me. It's sort of like embracing those same fundamentals in a more elegant way, which kind of gets to the principle of MIS in general. And of course, what is MIS? That's changed quite a bit over the years. And so I'm curious, in your own personal experience, I'm sure you probably encountered quite a few clinical scenarios that were common to you that you felt that the tools you had or the techniques were not entirely adequate. Do you remember what perhaps one of the earliest examples of that was for you?
Oh, there's quite a few that I can think of, but if we're limiting it to spine surgery, which I will for the moment, when I first started practicing, we were doing pretty large open hemilaminectomies with discectomies, and then they became smaller hemilaminotomies with partial extrusion or protrusion disc resections. And the intent continued to be toward minimizing injury to healthy tissues. And some of the early pioneers, including Parvis Cambon, started advocating for the transforaminal or through the Cambon's triangle disc resections using endoscopic techniques. So I think, there's been this progressive reduction in injury to healthy structures with an effort to ultimately affect the same surgical objective and yet protect the patient from harm. So I've seen that, obviously, if you look at burst fractures, the use of segmental fixation has enhanced both initial stabilization and subsequent recovery. We used to put all those people in progressive casts, Kydex-type jackets, etc., and that's not being done. And they're having both better outcomes and lower morbidity as a consequence of some of these interventions. I have not done this, but I'm well aware of these basilar vertebral nerve ablation procedures that are being done for some intractable discogenic pain, which is unrelieved with conservative care. And I find that very interesting and exciting. Again, I have no personal experience, but I have attended a number of conferences in which the presenters of this technique have basically raved about the outcomes and how enduring they are. And, that's a percutaneous radiofrequency ablative procedure with, virtually zero blood loss. And if you can take people who have debilitating back pain and ameliorate or eliminate their pain with that kind of a procedure, that's a dramatic advance. And I wish I had that tool and I'd been a practitioner when that was available, but it happened after my retirement.
It's been a very exciting development, even in the last few years. Of course, the clinical trials have been going on for quite a few years, but just in the last couple, has this become more popular in the U.S. I've had a fair bit of experience with it myself, and I agree. It's almost something to the point that's almost paradigm shifting in terms of adjusting how we think about axial back pain.
Yes.
The notion that not everything can or should be fixed with a fusion is something that we have to understand. But then understanding where we as individual clinicians fit into the wider range of things. And this is something that was a major impetus for this podcast, was having all the different specialties over
Sure.
under the umbrella of musculoskeletal medicine talk to each other so that we can understand things are changing at such a rapid rate. What are the proper indications, to your point a few minutes ago, and how can we all work together?
Yeah, one thing I would point out is there are very few people who are put in a box or cremated who don't have extensive degenerative changes in their spine. And yet we're not going to operate on but a small, hopefully, God willing, only a small percentage of those patients will have symptoms that justify surgical intervention. So we have to be careful about, interpreting radiographic studies and various scans and using the, I'll say, anatomic variations as a justification for surgical intervention. I'm sure you're very well familiar with the studies on asymptomatic adults who had MRIs and all of the positive findings that were read by competent radiologists on which no intervention was certainly justified. When we're talking about tumors, we're talking about basically degenerative conditions that were asymptomatic in a large percentage of those otherwise normal and healthy and patients who would be certainly resistant to any kind of suggestion that they needed back surgery. So, we're all undergoing this change in our lives as we age that involves desiccation and also some deformity. But it's only when these conditions reach certain symptomatic levels that we should be considering surgical treatment.
Such an important point, and brings to mind the old axiom of operating on the patient and not the picture.
Absolutely. And spine is, particularly, I'll just say, the most important tool for a spine surgeon, in my opinion, the most important tool is a good history, even more than the physical examination. The physical examination is usually confirmatory. It's rare that you'll learn something from a physical exam that you didn't learn from the history. And again, the scans, the radiographic studies usually are utilized when you want to confirm what your clinical impression is that you derive from the history, and also to localize the disorder. And so I would say one of my criticisms of colleagues, both orthopedists and general practitioners or primary care physicians, is they're very quick to order some diagnostic tests that no surgeon would act upon if they're appropriate in their indications. You wait until unless it's a real mystery. I mean, if you got patients with night sweats and pain at night and loss of weight, well, that's an indication for getting these studies. But if you have somebody with, radicular pain in a classical pattern and nerve root irritability that coincides with that, and they've only had symptoms for a few weeks, they've had no real conservative care, there's no need to get an MRI. Okay, they've got a disc prolapse or herniation, so what? You're not ready to introduce them to a scalpel. You're ready to introduce them to McKenzie lumbar extension exercises,
Sure.
Anti-inflammatories, maybe some activity moderations, things like that, and reassurance, because the majority of them are going to get well. And you just need to reassure them that the likelihood is they're going to get well, and don't expect it to get better in a few days or even sometimes a couple of weeks. It may take a month or 2 or 3, but as long as you see them centralizing their pain and progressing, you can keep reassuring them, and there's no need to go ahead and order the MRI. That's a waste, if you will, of resources, and it only serves to make the patient even more nervous, because now you've objectified something that they, as laymen, don't really understand. Oh, I've got a herniated disc. Now what do I do? Or
Right.
I've got a disc prolapse. Now what am I going to do? Okay.
Yeah, I think the one that so many patients come in and they say, well, what about the bulging discs? So don't care. As one of my
we make them
mentors
nervous because we don't just give them the kind of counseling that they deserve at the very beginning and reassure them that, look, you're not going to fall apart, and, you're not going to lose limb function overnight. We're here, and if you have a big problem, you just give me a call and we'll take care of it. But, just stay calm and follow the plan, and the likelihood is you're going to get better. You're going to get better. Even with a foot drop, the likelihood is you're going to get better. Give it enough time. But, obviously, if they're suffering enormously and they failed conservative care, well, then we have reasons and we have justification based upon various long-term studies to intervene surgically, but only under those conditions.
Thank you, Dr. Marino. So much wisdom in everything that you said there. And one of my mentors had a habit of saying to patients in clinic that this is just a gray hair and wrinkle of the spine, and which is so true. It's just because it's there doesn't mean it's painful. It can be, but it's not something to get all worked up about. And I have seen patients who end up going down, kind of a maximally invasive pathway because, of course, our MRI and our CT reports are very technical and go to great lengths to describe things precisely. And yet that language, that's something that we spend years in our residency and fellowships to become proficient with the vocabulary. And then now patients get access to their imaging reports almost instantaneously, and they have this onus put on them to understand stuff that many physicians don't even understand too well.
Yes.
It can
what
be very
is this
frustrating.
about modic changes here, doctor?
Right.
What am I supposed to do?
Oh gosh, yeah. Contentious topic for sure.
Yes.
And so much of what you said really resonates with me, and I think really resonate with a lot of people listening who, I think in general, most specialties have been gravitating over time to more minimally invasive, more elegant applications of treatment. And so getting back to kind of the innovation in your career, could you tell us about what was one of the earlier ideas that you had for an innovation that you knew you needed to take forward? You needed to make this into a product?
Well, maybe compelled rather than need, or had a great interest in doing is a better way to describe it. But when I saw that the various spine applications were pretty invasive, and I had my experience as a peripheral joint arthroscopist, I thought, gee, there's got to be some ways to reduce the, surgical intrusion here. And I do give, and I've mentioned him before, Parvis Camben, a great deal of credit for pioneering this area. So I went to see Dr. Camben and attend his course at the Graduate Hospital in Philadelphia. And, we had hands-on cadaver sessions and the like. And boy, when I was attending this, he was advocating for awake patient intervention. And I'm thinking, gosh, I don't like the fact that the patient can squirm and move while I'm putting instruments close to their nerve roots. And although, he's obviously a very, competent technician, I wish it was a little more controlled. And so I started thinking about a number of things, one of which was nerve monitoring, evoked potentials, electrified cannulas, electrified obturators, use of expanding cannulas, use of stereotaxic techniques to guide the instruments as precisely as possible. And I could see that if these various tools were somehow applied in spine surgery, it would open up opportunities for us to do procedures that were otherwise unavailable. And that was started inventing, if you will, some crude instruments and some early notions, and was fortunate enough to meet with a venture capitalist named Drew Senier with Enterprise Partners, who gave me an evening to discuss some of my thoughts with him. And he asked me to summarize them, and then eventually flew with me up to the Bay Area to meet with a guy named Joe Lacob, who was a partner at Kleiner Perkins Caulfield and Byers, which was a very, very, and still is a very prominent venture capital group. And they ultimately decided to invest in my ideas, and we started a company which they asked me to name, which was NuVasive. So that's how NuVasive started. And I had a single engineer who worked with me in the basement of my home to start producing some engineering drawings and early renderings that we then shared with a variety of thought leaders, spine surgeons, mainly academic spine surgeons around the country, to see if there was some interest and traction in developing these concepts. And there was. And that's kind of how the company started. And that's where I was able to, if you will, express some of my problem-solving, innovative, I'll say, interests and in spine.
Fantastic. I have always been fascinated and intimidated about the difference between our world and the clinical realm, and then more of the commercial, the venture capital. What was that experience like, getting that first exposure for you?
Yeah, so maybe there was, at the beginning, it was probably better that I didn't understand a lot of the, I'll just say, the technical and pitfalls of getting involved and starting an enterprise. I just thought, okay, look, I've got some ideas. I think I know how to articulate them. I'll tell my story. And if they like it, great. And if they don't, I'll move on. And that's kind of, I think that approach worked. I mean, most VCs fundamentally, after one of the basics which I now very much appreciate is they need to understand the market opportunity. Before they even want to hear the story, want to know, okay, is there a market opportunity that I might consider putting the dollars that I have at risk in? And once they see that there's a substantial market opportunity, they'll listen to almost any story. And sometimes they'll follow, like lemmings, the wrong path. I mean, we had a number of these experiences in spine surgery where VCs invested tons of money in, I think it was motion-sparing technologies. I mean, I think it were billions of dollars wasted in some motion-sparing technologies. I'm not talking about arthroplasty. I'm talking about technologies that involved basically sort of an elastic stabilization technique. And there was almost no science to justify it, but they knew there was a big market opportunity, and so they put a bunch of money in, and they lost a bunch of money in that. But anyway, I think it was very interesting for me. I was an orthopedist. I was practicing. I was seeing patients at night for trauma at times, and doing my normal clinical things. And then all of a sudden, I was flying to different parts of the country to present my ideas before very knowledgeable and very well thought of academic spine surgeons to consider. And I thought that was both flattering to me and very exciting at the same time.
That's amazing. How over your career, how have you seen or felt the balance between your clinical practice and these other endeavors on the more commercial or industrial side?
So it was a gradual transition. I didn't give up my day job, so to speak, in order to become a surgeon innovator. And I always felt and continue to feel that if you want to be a good surgeon innovator, you better remain a surgeon. You better be in the operating room doing the procedures and experiencing the shortcomings of current techniques while contemplating what you can do to make them iteratively better. Or if you have a spectacular idea and you want to do some kind of dramatic alteration in the approach, well, that's great, but those don't come along very often. Most of the time, they're small, iterative improvements that spine or other surgeons are able to afford the field. And but you got to be a spine surgeon, or you have to be a surgeon in general, or a practicing physician if you want to become an innovator. The advantage of innovation, I felt, was that there was a long cycle in problem solving. When you're a clinician, you're stamping fires out every day. You're addressing immediate patient needs and problems every day, every hour. When you're doing innovation, like the kind that I've done and want to think that I can continue to do, you have the luxury, if you will, of time to mull over, if you will, your thoughts and to get other people's input and to refine, if you will. And there was something I liked about that. I liked long-term problem solving sometimes more than stamping out fires.
Yeah, it goes into the difference of thinking fast and thinking slow, which are as different as slow twitch and fast twitch fibers.
Yes, I've definitely been accused of being the slow thinker many times. So yeah,
I don't think that's an insult at all. And for the reasons you described, it's such a necessary part of the process.
Yes, it is.
That's something that I struggle with, and this notion of winning slowly is something that I've heard quite a bit. And I'm the type of person that if I see something that kind of in the system that I'm working in that doesn't make sense, hey, why don't we fix this? Why don't we just, do it this totally new way? And then it becomes hard to win that way when you're very, just pushing forward headstrong. And so the ability to kind of sit back and take some perspective and incorporate those fires that you're stamping out day after day with the wider kind of big picture amalgamation of what you say, it's a very valuable skill, very difficult to cultivate.
Well, anyway, so I gradually, if you will, found a means of both doing my day job and spending time with talented engineers and business development people trying to, if you will, realize some of the ideas I was coming up with.
It's fantastic. And, of course, you've given us sort of the origin story of NuVasive. And now NuVasive, of course, is a very prominent member of industry and big part of many of the distributions of very common techniques that are done. Yes. And so obviously that's not something that happens overnight and takes many decades.
Not only did it not happen overnight, it didn't happen because of one or even a few people. There were a lot of people, many people, who made NuVasive successful. And I want to make sure that it's clear that my main contribution was at the very beginning. I mean, I was the founder, and I was, the first president, and I named the company, and I hoped at the beginning to set the culture of innovation. But there were lots of both talented business people, talented engineers, talented clinicians that all ultimately made NuVasive a commercial success. And they deserve the credit due to them for their contributions. And I'm certainly, I was a very small part at the very beginning.
Well, props to you for naming the company. It's a very good name. I like that name a lot. So you deserve a lot of credit for that, among the other things. And you're now working on a separate endeavor. And tell us a little bit about the particular project you've been focusing on in terms of the MIS bone grafting.
Yeah, so I'll just say in general, I would say that the fields, maybe more in spine than in other surgical fields, we need to be thinking about the value proposition and finding means to reduce costs but still get the desired outcome is probably something that we should spend a lot of time pursuing and considering. And when I was in practice, and certainly during my training, autologous bone harvesting was always an open, a fairly morbid type of procedure. And we did our best to try to improve upon that, but we were still using osteotomes, curettes, gouges, mallets, and we were stripping muscular aponeurotic attachments from the bone in order to access the cancellous bone, which was within these repositories, whether it was the iliac crest or the proximal tibia, the calcaneus, etc. And so I thought, look, we basically just want to get the cancellous bone out, and there must be a way to capture. We can use a tree find, but it doesn't really capture the bone. And so I thought, well, maybe I can come up with a means of actuating a tree find so that it captures the bone. And I can create an instrument that will create a small cortical defect percutaneously, through which I can take the tree find and insert it on different axes to allow me to basically remove as much cancellous bone from within with doing as little harm to the soft tissue attachments and with a very small osseous opening. And so, again, this is problem-solving kind of concept, and I came up with some ideas along with some engineering collaboration, particularly with an engineer named Jamil Obana, and even before that, an engineer named Dan Algren. And with the development of this minimally invasive technique, we eventually developed what's called the COREX device, which has undergone several iterative changes to improve it. And I think now we have a very reliable tool for percutaneous autologous bone harvesting. And I think the general orthopedic surgical field fails to recognize how low the morbidity can be when you convert this autologous bone harvesting procedure to a percutaneous procedure. One of my orthopedic partners had a 2-level cervical fusion, and his surgeon was reluctant to use the bone harvester, but he insisted that the surgeon do it. So it's not like the surgeon had a lot of experience. And this orthopedist told me, he said, "Jim, I'm not telling you this because you're, a partner and a friend, but I couldn't tell which tibia my bone was harvested from." Now, he had a cervical fusion, and he didn't know which of his limbs the bone was harvested from because it was so asymptomatic. And he said, I had to really look at the dressing, and post-operatively, I had no pain. So he said, I'm not sure every patient's going to have this experience, but it was a negligible discomfort. And yet, when you read the literature that's often cited about autologous bone harvesting, it's replete with very, very, I'll just say, discrediting type characterizations about how much morbidity, long-term disability and morbidity constituting 20 or 30% of the patients, and how the pain is worse than the actual operative site and all this stuff. Well, it turns out that when they cite that literature, it's all dated from more than 20 years ago. It also is very confusing because a lot of it had to do with back surgeries. And if there was a great study that looked at thoracic fusions versus lumbar fusions for the level of pain associated with the donor site. And as you might understand, patients were complaining of enormous donor site pain when they had a lumbar fusion, but almost no pain when they had a thoracic fusion. Because they, in their mind, if you look at the, the homologous, the thing in your
homunculus,
cortex,
I think.
Yeah, homunculus, yes, homunculus. There's just not a lot of cortex devoted to the lower back and localizing pain. So pain from your lower back, whether it's from your posterior iliac spine or whether it's from your operative site, are confused. And so also there was another study which asked the patient, well, which side was your bone harvested from? And they got that right about 50% of the time. So, I think there's been an enormous exaggeration. And to a large extent, this was a very calculated effort on the part of various biologic offering companies to hype their product and to discredit the gold standard, which still is the gold standard. And there's been enormous amounts of money being spent on biologic preparations, which are, to a large extent, very unjustified. I won't say completely, but very unjustified. There's several review articles on cell-based matrices, which basically said there's just no objective evidence that is not industry-sponsored to justify the premium costs associated with these bone grafts. I mean, it's not that allografts aren't valuable. They certainly are. But when you start doping them with mesenchymal stem cells and claiming that there's no, that they're immunologically privileged, which is not true. It's commonly expressed that the only time they're immunologically privileged is when you do in vitro testing. When you do any kind of animal studies in vivo, they demonstrate humoral and cellular immunity, immunologic responses. And mesenchymal stem cells do not produce bone. They have to differentiate into osteoblasts before they produce bone. And osteoblasts are absolutely not immunologically privileged. So this, there's a lot of hype, and I would say a lot of my colleagues have unfortunately not been critical in their evaluation of these expensive products. I mean, I can remember when BMP2 came out, and I remember the proponents giving these lectures and saying how well they understood the dynamics and how few, if any, complications actually exist, and how the dosaging has been well worked out and you better follow what the company recommends. And then within 3 years, we had, neuritis, heterotopic bone, massive soft tissue swelling, subsidence, loss of lordosis in segmental fixation, which is an absolute must. I mean, lordotic restoration and segmental fixation is one of the things I strongly advocate. And if you have your graft subsiding, then the pedicle screws are not able to bear the loads on their own, and they end up, because they're polyaxial the vast majority of times, they end up rotating, and you lose lordosis in the segment that's going on to fusion. So I think there's a lot to be examined critically about alternatives to autologous cancellous bone. I do think that demineralized bone matrix is very helpful, very valuable, and very powerful, and simply lyophilized or freeze-dried cancellous bone is a good product to expand or utilize in numerous circumstances. But some of these other preparations, I think, are overpriced and overblown and should be more critically considered.
It's very interesting how the pendulum has sort of swung, so to speak. I remember as I was preparing for this discussion, I was thinking about a patient of mine during fellowship who came in, and my attending said, okay, what operation has she had? And so I'm looking at her MRI, looking for screws or anything like that. Well, she's had a decompression here. What he was getting at was that she actually had a fully bony fusion, posterolateral fusion, not instrumented. And over probably 30 years, that had held up so well. And now her problem was simply some adjacent segment disease and focal tenderness at the donor site.
Yeah, with or without, I'll say, metal fixation, fusions in the past have not adequately restored segmental lordosis. And I can remember when I first had some of these ideas, going to a major university, talking to a past president of NASS, a very, very reputable and highly intelligent spine surgeon, and saying, I really think that restoring lordosis in any fusion level, even a single level, particularly at, L4 to the sacrum, where the majority of lordosis resides, is very important. And I remember him looking at me and saying, you really think so? He says, it's like a chain. He says, it's like a chain. So you lose a little lordosis here, you gain it at the other levels. So that was, and I mean, this is an industry thought leader, a very, very bright, capable spine surgeon, but he just, it was before it became really strongly advocated that sagittal balancing through restoration of lordosis was critical. And so we did a lot of fusions in hypolordotic or even kyphotic positions. and that put enormous strain on adjacent segments, trying to keep them upright. They were overcompensating and with their hyperlordotic motion segments above and below the fusion were ending up causing degenerative changes over time. So this took a while. So it's an area where I have a great deal of interest and strongly advocate for.
It's very interesting that, as you point out, with the COREX device, the cancellous autograft is the gold standard, and everything else is kind of measured against that. And one of the things I wanted to highlight with that story was just that patient had been fused just with standard iliac bone graft, and the fusion was immaculate. The other issues were sort of incidental to that. And so for a long time, we've understood, talking back to the fundamentals and the AO principles, how powerful autograft is. And now we've kind of swung in some different directions.
Yeah, I think a lot of surgeons are still under the impression that not only is there a morbidity associated with cancellous bone autograft, that there is an inferiority of that product relative to some other offerings like BMP2. And yet the Yoda study showed conclusively that there's no statistical difference. This is after looking at multiple studies. No statistical difference, no advantage, if you will, in fusion rates with BMP2 versus autologous bone. And yet there were significantly more recipient site complications from BMP2 than with autograft. So there's something to be considered there. And again, I think and it constitutes, I think, about 20% or more of the biologics that are sold, which is now, several billion-dollar industry. But cell-based matrices, surgeons need to look at that very closely. There's a lot of money being spent on these mesenchymal stem cell doped, basically cancellous bone grafts with some DBM. And I think they would be wise, looking at the review studies, to consider just using DBM and cancellous allograft rather than the more expensive premium-priced bone cell matrices, which are not justified from the literature review studies that are published.
Very interesting. I have to say, I've been very impressed looking at some of the videos for the COREX device. And one of the things that struck me instantly, and my fellow interventionalists, I think, will get this too, is that it's one of those light bulb moments where it's like, duh. I mean, it's why hasn't someone done this a long time ago?
Well,
and it's very reminiscent to me of what we're used to doing of an iliac crest bone marrow biopsy. Very, very similar principle.
I appreciate the compliment. I can tell you that without making this too much of a commercial, when I would use the COREX device, sometimes I would assist another orthopedist and they'd say, would you harvest some bone? And I'd use the COREX device and a representative of another company would be in the room. They'd say, wow, that was quick and amazing. He says, how'd you do that? And I said, we have this device and it works. He says, well, I'm surprised other people aren't using it. And I think the reason other people aren't using it is because it's there's a certain amount of shame associated with autologous bone harvesting. You're a surgeon now because, again, there's been a very effective marketing campaign to discredit autologous bone harvesting. And a lot of surgeons just frankly, it's more convenient to open a bottle than it is to harvest the bone. There's no question about that. But if you're looking for an outcome, assuming that their reservoir of bone is adequate for your needs, there isn't anything superior to autologous cancellous bone. I hope some surgeons will consider it and look at some of the harvest videos that we have on Trinity Orthopedics website, because I think it will be somewhat compelling for them to consider in some of their procedures where they need to get bone to heal.
Absolutely. I think it definitely recontextualizes the use of autograft, comparing the traditional open incision with multi-level closure, sometimes a surgical drain, to a single stab incision, being able to yield multiple cores from the same site by directing at different angles. So I was really impressed and really intrigued by that. and just kind of about the little nerdy technical aspect. So as you point out, the bone graft can be harvested from a number of sites. Tibia, as you said, sometimes calcaneus, but the iliac crest has kind of been the historical gold standard for that. So are the surgeons who are using this device typically using any sort of imaging guidance, or just kind of an old school, just going at it?
Right. So, I mean, obviously it's important to have some understanding of anatomy. I mean, you're a surgeon, so you got to know something about the anatomy there.
Something,
But,
hopefully.
the iliac crest and the proximal tibia and the calcaneus, these are subcutaneous access sites. You're not going through a bunch of muscle to get to them. So, I mean, you can palpate the bone, and even in an obese patient with pediculus, you can palpate the iliac crest. Now, the anterior crest is a little bit more challenging, I would say, is more challenging than the posterior crest because it's just not as wide. But we have a 7 as well as a 9 millimeter width harvester, and I would recommend considering the 7 for the anterior crest. I think the proximal tibia is a very, very underutilized location for harvesting, and it's a wonderful location because it's so easy to define. You can feel the joint line, you can feel the tibial tubercle. There's no real neurovascular structure at risk, and you can just make a small incision, and you can barely get your hemostat, a few millimeters below the skin until you're on the periosteum. So I like that for supine patients. For prone patients, the posterior superior iliac spine is a great repository, lots of bone there, easy to access. And you just have to remember the orientation of the pelvis and how it basically slopes from anterolateral to posteromedial, and you don't direct your instrument, anterior-posterior, because you won't stay between the tables. Now, we did design the instrument to minimize a variety of things. One was we made it a manual instrument so that you get immediate proprioception. You're not going to see the bone if you're doing it percutaneously. You don't need to see the bone. We have a trocar tip that has a shoulder stop, and you can just feel the resistance to rotation as you create the hole, and it keeps you from plunging, if you will, into the between the two tables. And then we have a chamfered surface on the end of the COREX to keep you between the tables. And as long as you're both feeling and hearing, because you can actually hear the microfracturing of the cancellous structure when you're rotating the bone harvester between the two tables, you can feel and hear. And when you get to the point where it's no longer advancing, then you need to stop. You're either up against the cortex or you're where the tables become so narrow that there's not enough room. And then you capture the bone, pull it out, harvest it, and redirect. And there's just a few things. They're important to learn, but it doesn't take very long to learn them.
Mm-hmm. Fantastic. And so what's kind of the volume that the device yields for a single core? And about how much are you usually harvesting for, say, posterolateral fusion?
So as you're harvesting the cancellous bone, it's slightly compacting. It's spongiosa bone. So, you're rotating, and on the front of the tree fine, there are some small cancellations to help microfracture the cancellous bone. But we're getting about between 2.5 and 3 cc's with each pass, depending upon its depth. We made the device long enough so that you can place it to a depth. Well, we have some markings on it, but anyway, typically the shortest distance you're going to go is about 5 centimeters. But surgeons that have done hundreds of these procedures tell us that you can get enough bone for a 2-level interbody fusion. And that's, you figure somewhere between 10 and maybe 15 cc's per level. So that gives you an idea of how much bone you can get once you become skillful at harvesting.
Very interesting. One of the things that really has always struck me about seeing patients who've had iliac crest bone harvesting in the traditional way is once you get used to seeing it on a CT, it'll jump out at you. It's very obvious to see. Even if the patient never tells you, you can say, I know you you had something done with a bone graft.
Yeah, so reconstitution is something that I think surgeons should be aware of. Obviously, if you have to go back and do another procedure and you've harvested from that crest, you should understand there's a good chance that you will not have reconstitution of the cancellous bone there. And you can, if you want, backfill with cheap, cancellous croutons to enhance the chances of for reconstitution. That's something I certainly think is a good idea, especially if you anticipate subsequent procedures and you think you need to go back to that level, to that side. But you should not be destabilizing the ilium, even if they don't reconstitute, because the cortex remains intact and all of the muscular and aponeurotic attachments remain intact. So, I think reconstitution is something to consider, particularly if you're thinking that you may want to go back to that site for bone in the future.
That's fascinating. So it just makes me think about things quite a bit differently, because maybe all you'll see as evidence of this MIS bone grafting is a just tiny tract, maybe a tiny little bit of scar, subcutaneous scar, which is kind of amazing comparing it to the very palpable and visible defects that are created in the traditional open way.
People used to have peritoneal hernias through large defects that were created at the time of harvesting. That's how invasive they were at times.
So tell us now with the COREX system, what context or what procedures is it most commonly being done with? You mentioned interbody fusion. Is that
I think interbody fusions, yes. We are also getting some initial, we're just starting, if you will, to introduce it to the foot and ankle surgeons. There's a lot of hindfoot, midfoot fusions that I think would benefit from using autologous cancellous bone. I think that trauma surgeons would find applications for delayed or non-unions or areas where they have some defects that they want to fill in. We're a small company, so we have a very limited capacity to reach out to the various surgeon disciplines. And a lot of what happens is word of mouth and promotion by independent surgical representatives. So, we appreciate the airtime you're giving us, and hopefully it'll cause some surgeons to consider it.
Yeah, absolutely. I certainly hope so. And I like the topic because I like the idea, because once you minimize one of the most invasive aspects of a procedure, it makes you think, how can this be done maybe entirely percutaneously or endoscopically, something that used to be done with big wax through the skin. And it actually brought to mind something I had seen recently. Seattle Science Foundation, who has an excellent YouTube channel, recently hosted a journal club, and the spine surgery group from University of Miami talked about their experience with a direct pars repair, and in the putting a percutaneous screw through the pars, and then initially using a tubular retractor, they were going in and decorticating the defect and packing it with bone graft. More recently, they've been doing that approach endoscopically. And so that blew me away, that entire treatment of spondylolysis, which otherwise would be doing a segmental fusion, doing it essentially percutaneously. And then if the graft harvesting is percutaneous as well, that's you've taken something that has been a very difficult surgical problem into something that is potentially done on an outpatient basis.
Well, I'm impressed that they were able to visualize, because there's no real potential cavity there to expand, and good for them. And I think if their results justify it, they'll probably get quite a few adopters.
I thought it was a very interesting technique. I'd recommend anyone listening check that out on the Seattle Science Foundation YouTube. But just one of the many kind of potential future applications of technology like this. And are there kind of any things maybe a little more on the vanguard that you'd like to see this expand into, aside from, you mentioned foot and ankle surgery, but maybe things that are just a little bit over the horizon?
I know that we've had limited use, but some tumor surgeons have used it. It might be appropriate for some biopsy applications. and or filling in some bone cysts. But I don't have any personal experience with that. So it's something that I would say is kind of an off-label indication. And those people who are, I'll say, pioneering those efforts would probably be better talking about the pros and cons of using it, because I have no personal experience with it.
Sure. I hope that there are people listening who are thinking about how something like this can be implemented into something that they do right now, and just to get people thinking a little bit more about refining approaches, as we talked about earlier. And so I find this whole thing very fascinating, and I appreciate you reaching out to discuss it. And as we conclude, I wanted to ask just kind of some general words of advice for you to current or aspiring physician innovators who juggle, as you did, clinical practice and many other responsibilities with that insatiable need to change or make something new. Just any general words of advice for physicians in that position?
Sure. Yes, I would. I do have some words of advice that are meant to be self-protective. When you're doing novel procedures with novel techniques and or instrumentation, exercise utmost caution for obviously primarily your patient's benefit, but also to protect you and your practice, because adverse outcomes can occur. And if you're involved in innovating, you're going to be very vulnerable to both criticism. Some of it's clearly justified, but you want to minimize the justified criticism. But I can remember hearing that one of the great innovators in spine surgery, Paul Harrington, almost had his medical license removed because of his very, very substantial contributions to the field of spine surgery. Because at the very beginning, I'm sure, Harrington hooks and rods were breaking, and there were a number of things that had to be worked out. There's some things you can do in a cadaver, and you should do them, but then eventually this has to transition to the patient population, and these patients are receiving unproven devices and technology. So one of the things I would say is be careful, try to be as minimally iterative as possible. Don't try to introduce too many new things at once. That was a big mistake I made, is I tried to do too many things at once. And I regret it, and I justifiably suffered because of it. And also I did have adverse outcome to one of my patients, which was a consequence, even though it was done under experimental protocols, experimental patient Bill of Rights and the like. I would just say that for those surgeons who are innovating, not only worry about protecting your patients first and foremost, but also be conscious that you're at risk when you're innovating, and you want to make sure that you're in the right setting and that you've done everything you possibly can to assure your patient of as much protection as possible, and also your own personal legal protection.
Such valuable advice, I think, and something that really bears thought among my specialty, especially. Something that draws people to interventional radiology is that it's always evolving, always changing, always kind of exciting new tech and everything. And so we get to be on the vanguard pretty much on a daily basis. But as you said, is sometimes changing too many things at once can introduce too many variables, and so we do always have to keep in mind kind of gold standards, and that's something why I've been one thing, just kind of specific example for me that has been really beneficial for me is taking a lot of time to learn about the indications for surgical operations that I don't perform, and understanding where that fits in, the kind of the morbidity and mortality that may be associated with certain techniques. But we talked about it a little bit earlier, is being able to have that difference between the fast thinking and the slow thinking. And when you have an exciting idea, it's natural to want to just blast forward with it full bore, and you're advocating for a more gradual and nuanced approach.
Yes, be reflective when you're considering and try, as I said, try to be iterative when possible so that you're not making too many dramatic changes in your approach, and so that you can fall back, if you will, on a time-tested alternative should things not be progressing as you had hoped.
Fantastic. Well, some excellent words of advice and wisdom, and I'm definitely going to be using those myself. And
Good
so
for you.
I really appreciate it, Dr. Marino. And
It's my
before we
pleasure.
wrap up, is there any closing words, anything you'd like to share with the audience, and ongoing projects? Where can people keep up with you and what you're working on?
I think we've covered enough here, and I don't want to, if you will, tantalize people with ideas that aren't close to being realized. It'll take some time, but we're still working on some things, and maybe I'll have something else to contribute to the field. I hope so.
Thank you so much for listening. If you haven't already, be sure to follow, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable MSK on Instagram, X, or LinkedIn. BackTable MSK is hosted by Jacob Fleming,
Michael Barraza,
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles, Josh McWhirter,
and Josh Spencer. Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.